And thank you, Dr. Mahdi, for giving me the opportunity to be involved in this wonderful course. Our first lecturer is, as everyone knows, the eminent Dr. Samir Elansary, Professor of Intensive Care Medicine. Hello. And he's going to talk about muscle disorders in the ICU. Thank you, Professor.
Okay, thank you.
Do you mind, please, if we take the question after each lecture, because it will be easy for video editing?
Okay, so when Dr. Elansary is done, we'll take like 4 questions off the chat box?
Yes,
okay.
please. Yeah, thank you.
Wonderful, thank you.
Thank you. Bismillahirrahmanirrahim. Thank you all. Thank you, Dr. Barbara, for this nice introduction. And good evening, our colleagues, and good evening and welcome our attendees. I am going today to speak about some of the common problem in the ICU, which is muscle disorders in the ICU. Really, all the muscle disorders in the ICU share the same problems or the same considerations, like how to diagnose or difficulty in diagnosis and how to manage and the restricted routes of management and so on. Today, I am going to just highlight the most common causes or most common underlying disorders which we face commonly in the ICU. Of course, if we start from the central nervous system, or maybe brain injury, or maybe spinal cord injury, and going down to nerves, maybe some sort of disease affecting the peripheral nerve, like Barré syndrome, critical illness neuropathy. Also neuromuscular junctions as myasthenia gravis, botulism, tetanus. In the muscle ending to the muscles, we can see polymyositis, myopathy, intensive care myopathy, and I think we know there are many diseases affecting the muscles and affecting the neuromuscular unit. And as most of us know, there are maybe more than 600 diseases affecting our nervous system. And so the differential diagnosis really in this field is highly difficult. And the diagnosis also may be difficult to some extent at start. We have and also even the facilities or the lines of treatment is restricted and highly costly. If we start with a common disease, which is Guillain-Barré syndrome, and as we know, this disease is maybe diagnosis and the management of it may be complicated. And its clinical presentations and disease course are mostly heterogeneous, as we will see. And so the international clinical guidelines are currently available for, depend on some literatures, depend on case study, depend on some expertise, and so on. It is an acute onset, always starting acutely, and some cases, some start with chronic presentation. The acute onset starts with ascending sensory motor neuropathy affecting the periphery first and going up. And it is an acute inflammatory demyelinating polyradiculoneuropathy and mostly demyelinating, but some item or other types affect the axonal nerves, as we will see. It is a rare disease, but potentially fatal disease, and it is immune-mediated disease of the peripheral nerves and the nerve root that is usually triggered by previous infections, even subclinical infections, some infection with influenza, maybe cytomegalovirus infection, Epstein-Barr virus, some pneumonia, and even with vaccination, especially vaccination against influenza. The body started forming antibody against the gangliosides, which reside at high density in the axolemma and other component of the peripheral nerve. and also in association with complement activation and the infiltration of macrophage and edema are typical characteristic of affected peripheral nerve and the nerve root in patient with Guillain-Barré syndrome. There are 10-step approach to diagnosis and management of Guillain-Barré syndrome. If we look to this figure, it simplifies actually how to diagnose, how to proceed, and how to manage this disease. And I think we have to apply these steps in most of the muscle diseases. And most of our talk today about Barré or about botulism or about another disease, it I think apply to most of the muscle diseases which you face in the ICU. How to diagnose the Barré syndrome? It is a rapidly progressive bilateral limb weakness, and it may include also sensory nerve affection, and also maybe hyporeflexia. Most of the cases excepting hyporeflexia or areflexia, as in Miller Fisher, also may extend up and causing some sort of bulbar palsy and facial nerve and cranial nerve affection, causing ophthalmoplegia and ataxia. How to diagnose Barré? Check the diagnostic criteria, and most of the muscle disease, we apply these points also. Exclude other causes of the muscle disease, consider routine lab test and the CSF examination, specifically in Barré syndrome. It will show us increased, in most cases, increased protein, may be normal in the early stages, but after that, will exhibiting increase in the protein level in the CSF. But the cell is there is no increase in the cells. There is no biliocytosis. Also, the other lab tests must be done to exclude other causes of the muscle disease. See, electrophysiological study, this must be applied in any muscle disease. We can see the latency of nerve action potential, conduction. We can see F wave. We can see many characteristics for the post-tetanic potentiation, post-tetanic inhibition. It helps us in differentiation of the different type of muscle disease. Because muscle disease really, it may be difficult in diagnosis sometime, especially in the early stages. When to admit the patient to ICU, when the patient is starting to exhibiting some sort of respiratory impairment, or he is going to respiratory failure or respiratory distress, or the patient becoming to exhibiting progressive weakness and severe autonomic dysfunction or dysautonomia is one of the commonest factors which causing us to admit the patient to ICU, because it causes high mortality. When to start the treatment for the patient, really there are different opinions in this field. Some prefer early intervention, especially by plasmapheresis or by infusion of immunoglobulin in such cases. Others ask to wait till some weakness or some evidence of the disease becoming clarified and becoming evident. Treatment options in Barré syndrome, as we know, it is limited and it is restricted to intravenous immunoglobulins, 0.4 gram per kg daily for 5 days. For children, we can give this dose over 2 days, not 5 days. Some prefer it and some prefer over 5 days. Plasma exchange also the dose 200 to 250 ml per kg for 5 sessions. And some ask if we can repeat this treatment if the patient exhibiting slight improvement or exhibiting not dramatic improvement. Yes, we can repeat after some times in some patients who exhibiting some deteriorations after the initial treatment. Monitoring also, as in many muscle disease, we have to record the muscle strength, the progress, the respiratory function, especially through spirometry, vital capacity, forced expiratory volume, different pulmonary function tests to evaluate the progress of the disease. Also, we have to look to the swallowing functions and the difficulty in swallowing or getting rid out of secretions, especially in cases of cranial affection of the Barré syndrome. Also, the autonomic functions is very important. And as I said, this autonomia and severe arrhythmia in some cases during evening positioning of the patient or moving the patient exhibiting fluctuations, severe fluctuations in heart rate, blood pressure. Also, they may complaining of bladder, bowel control problems and so on. We have to look also to the complications, especially early complications in Barré syndrome and also in any muscle disease, really. We have to be careful for DVT, prophylactic anticoagulant to avoid DVT for those patients because they are not ambulating and the muscle tone is low and the DVT is common. Also, we have to look for choking and aspiration and atelectasis and so on. So we have to guard against and we have to intubate the patient early. Infections also is very common, especially pulmonary infection, deep venous thrombosis, pain. In some stage of the disease, most of the patient with Barré syndrome suffering from some sort of muscle pain. Also delirium and depression, very common in all muscle diseases and specifically in Barré syndrome. Urinary retentions, constipation, corneal ulcerations, where we have to protect the eyes and take care of the eye. Dietary deficiency, very common, and very common in ICU to see patient with malnutrition, which predispose to critical illness, myopathy, and cachectic myopathy, which may be difficult to differentiate from Barré syndrome in some situations. Pressure ulcers is very common and it depends on good nutritional state and also in positioning of the patient, physiotherapy, hemodynamic state. All these factors affect the development of pressure ulcers in those patients. Compression neuropathy, very common in such patients because muscle tone is very low and they are liable for compression. Limb contraction, and so we have to move the joints and to ambulate the patient and to participate with, ask the help of physiotherapy to avoid these complications. Monitoring, as we covered that, clinical progression is very important with treatment, and we check if the treatment giving us a good result, or we have to repeat, or it is not optimal. And repeating treatment, but some, as I told, we sometimes repeat the treatment if there is some response and if we suspect there is progression of the inflammatory state of the disease. Predicting outcome and long-term care, it is very important also, especially in Barré syndrome and in all muscle disease patients, especially the psychological state and the lifestyle after that. Most often, unremarkable infections precede the Barré syndrome. Mostly the patients complaining, especially of Campylobacter jejuni. Can be in a quarter of our patients, they suffering from previous Campylobacter infection, Zika virus, as here before, cytomegalovirus, mycoplasma pneumonia, Epstein-Barr virus, influenza virus, and some vaccination, especially against influenza vaccine. Mostly influenza vaccine, some patients and some vaccines exhibiting this. Absence of antecedent illness doesn't exclude a diagnosis of Barré syndrome. Suppose the patient is not suffering from previous infections. This is not meaning the patient has no Barré syndrome. May be some sort of autoantibody or autoimmune reaction to other factors. Barré syndrome is usually begin abruptly and especially the distal and symmetrical in most of the cases, and start also with paresthesia and quickly followed by progressive limb weakness. Progression is rapid really with 50% of patients reaching clinical neither by 2 weeks and more than 90% by 4 weeks. If I find my patient developing weakness and paresthesia and before within 24 hours or after 4 weeks, this is not Barré syndrome, and I have to search for another cause of the problem of in such patient. Always it takes from 2 weeks to 4 weeks to give me the full picture of Barré syndrome. Before 24 hours or after 4 weeks, accepting the patient morbidly after 4 weeks, this is not Barré syndrome. In patients who reach maximum disability within 24 hours of disease onset or after 4 weeks, alternative diagnosis should be considered. 80 to 90% of patients become non-ambulatory during the illness. Pain is prominent in 50% of patients. Distal symmetrical weakness. Reflex is decreased, reflex action is decreased or absent in most patients at presentation and in almost all patients at need. Most of the patients, except in some. But I want to say, Barré syndrome is highly difficult disease in its diagnosis because there are, as we will see now, there is an overlapping symptoms. It is not distinct symptoms or accurate symptoms, or we can't say it is consists of paresthesia or ascending or descending or cranial only or dysautonomia. No, we have in many patients a different figure of presentation and different pictures of presentation as we will see now. Although Barré syndrome is essentially a motor neuropathy, sensory dysfunction is seen in few patients. And sometimes we see sensory manifestations only in very rare cases of Barré syndrome. Facial or pharyngeal weakness is commonly seen in Barré syndrome. Diaphragmatic weakness also, due to phrenic nerve involvement, is also common. Dysautonomia is one of the most problematic complaint in Barré syndrome. Hypotension, hypertension, arrhythmia, tachycardia. As I said before, just you manipulate your patient, moving him from side to side, he may be arrested in front of you. And so take care of this autonomia and some other diseases, muscle disease, excepting this dysautonomia. And I think you saw it also in acute cervical injury and spinal cord injury. Axonal subtypes of Guillain-Barré syndrome may be manifested as a pure acute motor axonal neuropathy, just the motor nerve affected, or acute motor and sensory neuropathy also we can see. It is caused by antibody which attack the gangliocytes at the axolemma of the nerve and also participating with complement activation and the invasion of microwave to the axolemma and causing edema of the nerve and in some other types demyelination of the nerve. About quarters of patients with Barré syndrome had Campylobacter jejuni infection, and so try to check this microbe. Diagnosis: progressive weakness in both the upper and lower extremity within 4 weeks, along with areflexia is essential requirement for diagnosis, and elevated CSF protein concentration with normal cell count, not exceeding 50 cells per milliliter, and so no paleocytosis and Barré syndrome. But suppose you find that tapping the protein level is low, maybe you can't exclude the Barré syndrome. As you see here, the pattern of symptoms in variants of Guillain-Barré syndrome, we see many different patterns, about 25 or 30 patterns really. This pattern, I just summarize it. We can see the classic sensory-motor affecting motor and the sensory nerve affecting the body or the body. Maybe pure motor only, and maybe paraparetic. The patient to look like paraplegic. Sometimes we think it is a spinal injury and causing motor and the sensory affections. We can see also the area of the bulbar area or the pharyngeal area with cervical and brachial and arm weakness and sensory loss in the upper arm, and also with dysphagia and weak coughing and so on. It could be in another pictures bilateral facial palsy with paresthesia in the distal area of the limbs, or maybe pure sensory, and it is very rare, pure sensory really. Or in the form of Miller-Fisher syndrome, which consists of ophthalmoplegia and areflexia and ataxia, 3 items. Ophthalmoplegia affecting the eye muscles, and also ataxia, and areflexia, no reflex action. If this type lost consciousness or if becoming drowsy or affected the consciousness or becoming not concentrating also, it will be Baker-Stuff brainstem encephalitis and the pyramidal area or the brainstem area will be affected. This is a simplified figure to show you the Barré syndrome is not a distinct entity or not easy in its diagnosis. There is an overlapping symptoms and signs, and so its diagnosis may be difficult in some cases. Baker-Stuff brainstem encephalitis also usually present with symptoms resembling Miller-Fisher syndrome, which consists of psalmoplegia, ataxia, and areflexia, in addition to loss of consciousness and brainstem dysfunction, including impaired consciousness and the pyramidal tract signs. Features required for diagnosis, it is Barré syndrome. To be sure, it is a Barré syndrome. Progressive bilateral weakness of arm and legs, initially only legs, may be involved. Absent or decreased tender reflexes in the affected limb. Pain is prominent in 50% of patients. Relatively symmetrical weakness. Symmetrical weakness. Progressive, this is the most figure or most characters of Barré syndrome. Progressive phase lasts from days to 4 weeks. Relative symmetry of symptoms and signs. Relative mild sensory symptoms and signs. Cranial nerve involvement, especially bilateral facial palsy. Autonomic dysfunction, muscular or radicular back or limb pain. Increased protein level in CSF. Normal protein level doesn't rule out the diagnosis. Electrodiagnostic features as latency and delay in conduction and F wave and so on, is characteristic to Barré syndrome. But we have to raise the red flags and start to think in another problem, not Barré syndrome, if we find these points. If the fever is at present, a patient present with fever at onset of the disease. If there is severe pulmonary dysfunction with limited weakness at onset. If there is severe sensory signs with limited weakness at onset. If there is persistent bladder or bowel wall dysfunction or bladder or bowel dysfunction at onset, or sharp sensory level, maybe spinal injury, or marked persistent asymmetry of weakness, always Barré syndrome symmetric. Lab also increased number of mononuclear cells in CSF or polymorph nuclear cells in CSF, marked biliocytosis, and in such cases we have to think in another problem, maybe some infection, HIV, cytomegalovirus, maybe leptomeningeal malignancy or other underlying cause at lymphoma and carcinoma. We have to think in another problem, not Barré syndrome, if we find this point in the patients. Not asymmetric, patient suffering from fever at start, patient suffering from sharp sensory level, and so on. Barré syndrome is a monophasic illness, and although so many patients can deteriorate after first stabilizing or improving with therapy, sometimes you give a treatment and plasmapheresis or immunoglobulin, and the patient accepting some improvement and doesn't deteriorate. The treatment-related fluctuation, we call it treatment-related fluctuations. And in such situations, we have to repeat the treatment. We have to push the treatment again, better maybe. And the relapses of GBS can occur in 1 to 5% of patients. And if it is relapses more than 2 or 3 times, I think it will be a chronic inflammatory demyelinating syndrome. Baker-Stuff brainstem encephalitis, as I told, it is mostly it is like Miller-Fisher syndrome, also included in Barré syndrome, which is diagnosed by areflexia, ataxia, and ophthalmoplegia, in addition to some pyramidal affections or loss of consciousness. And in such situations, maybe there are too much antibody against or too much antibody against the ganglioside in the axonema of the peripheral nerve. There is another figure or another disease entity of the Barré, which is acute ataxic hypersomnolence. The patient coming with drowsiness and coordination problems mostly, but no muscle weakness can be detected. This is called acute ataxic hypersomnolence. And so we saw How much this disease is difficult because of its overlapping signs and symptoms. Becker stuff brainstem encephalitis characterized by rapid onset of ataxia, areflexia, and a disturbance of consciousness. Recurrent episodes have been reported. MRI abnormality in the brainstem have been reported in 11%. It is often overlapping with sensory motor Barré syndrome. What is the management of Barré syndrome? I think it is not for the pathology and description of the disease. As I told that first, we have limited tools to manage such diseases. We have only the intravenous immunoglobulin and the plasmapheresis, and it is very important for management. But actually, the management of complications and the management of the disease itself and the progress and the sequel of the disease in any muscle disease, not only in Barré syndrome, is very important. Avoid DVT, avoid bed ulcers, avoid good nutritional support, good psychological support, avoid depression, avoid delirium, avoid many complications in the patient suffering from muscle disease. And it is common manifestations. The most important item in management of muscle disease in general and Barré syndrome specifically is intubation indication. If your patient has exhibiting inadequate ventilatory effort, if your patient is exhibiting poor airway protection, you decrease the level of consciousness and he is liable to aspirations and atelectasis and pneumonia and potential for neurological deteriorations, we have to intubate. And don't forget 20, 30, 40 rule. 20 vital capacity, if the patient exhibiting less than 20 cc per kg for vital capacity, you have to intubate. If the patient exhibiting less than 30 cc per kg maximum inspiratory, 30 centimeter water, maximum inspiratory pressure, you have to intubate. If your patient exhibiting maximum expiratory pressure less than 40 centimeter water, you have to intubate. These are 20, 30, 40. 20 for vital capacity, 30 for maximum inspiratory pressure, negative inspiratory pressure, and 40 for maximum expiratory pressure. 20, 30, 40 rules. But really, we don't depend in muscle disease on spirometry or pulmonary function test. We depend mostly, as I told always, on clinical. Don't wait to measure, don't wait to make blood gases. Your patient will not exhibiting hypercarbia except in the late stage, except in the dying stage. He will exhibiting hypercarbia. Don't wait for deoxygenation. The muscle Barré syndrome or the other muscle is not manifested by deoxygenation. Deoxygenation and the hypercapnia and you are late signs in muscle disease. Don't depend on such investigation. You have to depend on your clinical sense. You can find, you look to your patient, he can't swallow, he can't cough, he can't raise his head, muscle power is low, muscle power. You have to arm yourself and intubate your patient. Plasmapheresis, the early, and I told them, really in most of the research and in our experience, as early as possible, plasmapheresis give you a good prognosis and a good result. And even in the stage of paresthesia, if you predict the Barré syndrome in the stage of paresthesia and the patient just coming to you after some infection and complaining of some paresthesia and some weakness, weak weakness, you have, if you start plasmapheresis rapidly, your patient will be recovered rapidly. 5 exit change, about 200 to 250 ml per kg over 10 days or over 5. Intravenous immunoglobulin, as I said, 2 grams per kg over 2 to 5 days. In children, we can carry it in 2 days only, in adult in 5 days. Some pediatric prefer over 2 days. Some advise plasmapheresis for intravenous immunoglobulin, not so efficient and costly and not effective. Even if it gives you some, maybe some slight improvement, I think not not mandatory or not beneficial. Steroid treatment is not beneficial in Barré syndrome. Steroid treatment not beneficial in Barré syndrome. Not been but it carry its complications, osteoporosis, infection, immune suppression, and so on. Also in acute cervical injury and spinal cord injury. Don't give steroid. No need for steroids. Treatment-related fluctuations, indicated that the treatment effect has worn off while the inflammatory phase of the disease is still going. And so we can, as I told, we can repeat our plasmapheresis or repeat our intravenous immunoglobulin for such patient. Autonomic dysfunction or dysautonomia, as I told, it is very common and very catastrophic complications and lead to high range of mortality, and so take care of dysautonomia and try to treat it. These are important complications of Barré syndrome and even most of the muscle diseases. This is the most common complication. Choking, cardiac dysrhythmia, hospital-acquired infection, pneumonia, urinary tract infection, bulbar and facial palsy, immobility, bladder dysfunction, mechanical ventilation, pain and tactile allodynia, depression, urinary retention, corneal ulceration. All these complications are common to all muscle disease, not only for Barré syndrome. I shift now to another problem in ICU which we face, which is tetanus, or which is caused by Clostridium tetani, and as you know, which is a locked jaw syndrome, and causes of stillness after that when the back muscle is contracted, and it starts, as you see, just with a wound here, infected wound, an anaerobic area, anaerobic medium for growth of Clostridium tetani, and then starts the muscle of the face starting to be tonic, and the patient suffering from locked jaw and rhizus sardonicus appearance, and after that, and becoming impressed in breathing. This wound here, endospores here can be introduced in the body through the puncture wound, especially the rusty nails and the anaerobic area or urine area and agriculture area and wet area. All these carry the Clostridium tetani, which causes tetanus or causing which harbor the anaerobic bacterium Clostridium tetani. Even patients with heroin users, they can inject themselves with heroin and causing some sort of tetanus. It can carry the rusty nails. Surgical procedure also, intramuscular injection, compound fracture, dental infections, animal bites. All these can cause tetanus because it incorporates, if not clean, incorporates the Clostridium tetani. Signs, symptoms, and tetanus often begins with mild spasm in the jaw muscles, also locked jaw or trismus, and then the facial muscles become contracted and give you appearance of rhizus sardonicus, and the tetanus toxin or tetanus was being specifically block the release of neurotransmitter GABA and glycine from inhibitory neurons, and so the muscles stay in a state of contraction. And so we saw many patients really suffering from generalized tetanus. And such a patient, I advise, if you face patient in ER coming with you with generalized tetanus, don't hesitate, make tracheostomy. If you can't intubate, proceed. Or even if you can intubate, proceed for trach, because this patient will stay in the ICU more than 1 month. Because he exhibiting severe contractions and the, I think, intubation for a long time, it is carry its complications and its hazards, and so better to tracheotomize this patient from start. With the help, of course, of benzodiazepine, any muscle relaxant drug, and also with muscle relaxants, and proceedings with better for the patient. Because such a patient, even when you come in front of him, when you speak to him, when you touch him, he becoming the attacks of contraction. Because the inhibitory pathway is inhibited by tetanus toxin or by tetanus plasmodium. And so no relaxation of muscle, no cholinesterase actions after the acetylcholine action. And so the muscles stay in a contracted state. It is very painful and may cause fractures in some patients. And so this, but it not affect the consciousness, and the patient is fully conscious. Other symptoms of tetanus may include sweaty headache, also dysautonomia and increased heart rate, decreased arrhythmia, hypertension, hypotension. All these manifestations could be detected in tetanic patient. Onset of symptoms is typically 3 to 21 days following infection, and may be more than 1 month. The patient incorporating the bacterium and do not manifest it except after a long time. But mostly within 3 to 21 days, the patient becoming manifesting of the disease. Recovery may take months. We saw patients take several months to recover from this disease, and actually the patient who recovered in ICU from tetanus explain or clarify how good this ICU, because these patients need every sort of support in the ICU, hemodynamic support and nutrition support and physiotherapy, and these patients need highly specified care in the ICU. Recovery may take months. About 10% of cases prove fatal, really, it is a fatal disease if not treated accurate. Diagnosis is based on the presentations, tetanus symptoms, and doesn't depend upon isolation of bacteria. Even if you're not, because which is recovered from the wound in only 30% of patients. Not every patient you can't isolate the bacterium from. And it can be isolated from people without tetanus. Some people have harboring the organism, but in the gastrointestinal tract. There is test, very simple test really for diagnosing the tetanus. Spatula test. Just you can introduce the tongue depressor inside you as a patient, and the touch that you will provoke the convulsions and the locked jaw. The ordinary response for a spatula test, if you introduce something, the patient will gag and vomit and cough and so on. But in such a situation, the patient will start to beating the spatula and you elicit the contraction of the face muscles. And even, I said to you, even the patient not waiting spatula test, the patient just you speak to him, any stimulus, just touch him, he will start contraction and severe contraction which persists for minutes. And it is a repeated contractions, not only one time. Incubation period, the incubation period of tetanus may up to several months, but is usually about 10 days. And this is the rule, really. The farther the injury site is from the central nervous system, the longer the incubation period. The longer the incubation period. The farther the injury site is from the central nervous system, the longer the incubation period. The shorter the incubation period, the more severe the symptoms. Types of tetanus, there is generalized tetanus, neonatal tetanus 4 to 14 days after birth, local tetanus, and cephalic or cephalic tetanus. Both vaccination and tetanus immunoglobulin are recommended and are the only treatment for such patient, in addition to the supportive management. As I said, the patient needs supportive management for everything. The wound would be cleaned and any dead tissue must be removed. We can give metronidazole is the best. We can give diazepam. Penicillin really blamed, maybe provoke some convulsions, and so we not like it. Severe tetanus, we can inject the human tetanus immunoglobulin, inject intracephalic. You can inject it intracephalic, increase the clinical improvement from 4% to 35%. Tracheotomy and mechanical ventilation for 3 to 4 days, and caring patient on ventilation is very important. Severe tetanus also, the magnesium sulfate is very important in such situations. And I saw many patients not responding to even muscle relaxant, and we enforce it to increase our doses of muscle relaxants. The magnesium is really good, give us a dramatic response in such patients. And we give it through infusion, 1 gram, 2 grams, 3 grams, every hour for such patient. Very important in addition to benzodiazepine. As you know, benzodiazepine action is muscle relaxations, in addition to anti-anxiety, anti-apprehension, and improving the patient's situations and ameliorating some side effect of the psychological problems. Severe tetanus also, the dysautonomia is, as I said, is very problematic, and so you have to arm yourself with leptalol, beta blocker, magnesium, clonidine, nifedipine, and other drugs as diazepam and muscle relaxants, very important. The other disease which I wanted to mention here, myasthenia gravis or myasthenic crisis. And in myasthenic patient, as you know, there is antibodies. As you know, there is antibody against the acetylcholine receptors post-synaptic to differentiate it from the Lambert syndrome, which is pre-synaptic block. In myasthenic syndrome, the patient becoming a feature of weakness, inafatigability, ongoing effort rapidly provoke worsening weakness, strength improve with rest, fluctuation of severity over time. The patient becoming in the morning, going up in the morning, very good, well, and by time he becoming weak and he can't swallow, he can't speak, he can't smile, he can't open his eyes, dropping and so on. And so there is some sort, there is here post-tetanic fate, not post-tetanic potentiation as in Lambert syndrome. Lambert syndrome, which affects the calcium channels, affect the presynaptic, respond to electrophysiological study, there is post-tetanic potentiation. But in myasthenic crisis, post-tetanic fate, the patient exhausted by repeated stimulations. Patient exhibiting normal sensations, normal deep tender reflexes, not like Barré syndrome, normal pupillary reflexes. Only eye deviation, you see here, deviation of eye and the dropping of eyelid in a person with myasthenia gravis trying to open her eyes. Antibody accelerate degradation of acetylcholine receptors, decreasing the number of receptors on the post-synaptic membrane. Distributions eye and the bulbar muscles tend to be affected, involved early, and only skeletal muscles are involved, not the pupils. Generalized weakness can also occur and involving diaphragm and the limb after that in some patients. Diagnosis of myasthenia gravis, we can give just the anti-acetylcholine, it is the anti-acetylcholine antibody, sensitivity 80%, or no detectable antibody, seronegative myasthenia could be diagnosed. In some of patients not accepting the anti-acetylcholine antibody we can't find, but the diagnosis is or seronegative myasthenia gravis. Diagnosis of myasthenia gravis, also eye SPECT test is very important and very simple and carry a high sensitivity and high specificity value. Just you put eyes on the upper eyelid to potentiate the action of the receptors, and the patient started to strengthen the muscle, and the patient started to raise his legs and becoming improved. The other test, which is pharmacological hydrophonium, as you know, it's a short-acting anticholinesterase. You give it 2 milligram. If not effective after 1 to 2 minutes, you can increase to 8 milligram, but take care of its drawbacks. Bradycardia, some sort of cholinergic stimulation. And we have to differentiate between myasthenic crisis and cholinergic crisis. Because as you know, myasthenic patient is treated by anticholinesterases, the enzyme which distracts the acetylcholine to give chance to acetylcholine to build up at the neuromuscular junction, and so to potentiate the action at the acetylcholine receptors. If you give too much doses of acetylcholinesterase inhibitors like idurifonium, pyridostigmine, neostigmine, you will predispose your patient to another crisis, which is cholinergic crisis, which looks like organophosphate poisoning, which occur in the war, and we treat it by atropine and ralidipsime and so on, which I think you remember, most of you remember the Gulf War, and we started to arm ourselves by this item of drugs, ralidipsime and atropine, to antagonize organophosphate poison. And so there are two main problems in myasthenic patient: myasthenic crisis and cholinergic crisis. Myasthenic crisis result from the disease itself, exaggerated disease, exaggerated inhibition of the acetylcholine receptors. Cholinergic crisis, exaggerated response to or excessive dose of anticholinesterase drugs like idurifonium and pyridostigmine and neostigmine. Idurifonium is a short acting, and so we diagnose with it. If it gives improvement, the patient suffering from myasthenic crisis or myasthenia, the graves. If the patient not responding, this patient not myasthenic, and we have to seek for another problems. Treatment in such a situation in myasthenic patient, we use pyridostigmine, which is a long-acting anticholinesterase. and exhibiting less side effect, less cholinergic side effect than neostigmine. And it could be taken orally, and the dose from 60 to 120 milligram every day or every 12 hours, or we can increase. Every patient really need manipulation of the need titrating the dose of the anticholinesterase for him, especially after operation, especially after thymectomy. The patient may take 120 milligram per day or twice daily before the operation, before thymectomy. After thymectomy, you have to manipulate the dose requirements. Otherwise, you will introduce your patient or produce cholinergic crisis. Also, in addition, we don't forget the plasmapheresis in such patients, which is very important, especially before thymectomy. We prefer to make plasmapheresis, and also other immune suppressive therapy to decrease the total concentration of antibodies which are present.
We have 3 minutes left, Prof.
Oh, I am always unlucky, Dr. Saad. The time is tight. Really, I wanted to speak about another problems in our ICU muscle disease, as botulism, as muscle disease itself, as Duchenne atrophy or polymyositis, or critical illness myopathy, or critical illness neuropathy, and other diseases which affect the neuromuscular unit in our ICU. But I think the time is not enough as usual. And so I have to stop at this point. And don't forget in cholinergic crisis to use glycopyrrolate or hyoscyamine, because it is less in its blocking and its side effect if the patient manifesting excessive cholinergic crisis. Steroids may be used, but gradual using of steroid in myasthenia, or start by small dose, or wait till the patient exhibiting improvement and then start steroids to enhance the clearance of antibodies. Thymectomy is very essential and for myasthenic crisis, but we have to prepare the patient with pre-thymectomy plasmapheresis. Some ask if we can use high flow nasal catheter or BiPAP to myasthenic patients. We can in the early stages, but not in patient deteriorating and exhausted. We can't use BiPAP or high flow nasal catheter in exhausted patients. We can use it in early stages of myasthenic patient exhibiting some breathing difficulty, just to enhance the breathing power. But after that, we have to, if the patient deteriorates, we have to intubate and treat the patient. Decision to intubation. Intubation is a clinical, as I said, clinical decision, not depend on spirometry or blood gases or vital capacity or negative expiratory pressure or forced expiratory pressure. Depend on clinical evaluation. Don't wait till patient accepting hypercapnia. This is a late, extremely late finding in this context. And I think enough this our talk today about Barré and also about tetanus and myasthenia. We postpone botulism and other disorders to next lecture.
Thank you, Prof. We'll go to Barbara because we have no time, and great pleasure to have you, Prof, tonight. Barbara, all yours now.
Thank you for that wonderful lecture, Professor. It's wonderful. I think we have a couple questions for you. Here is the first question. Let me see. It says, Professor, you have mentioned that the rate of plasma exchange would be 200 to 250 milliliters per kilogram for 5 sessions. Is that right?
Yes, over 5. In which disease? We always use it in 5 sessions. Some using it for 6 sessions or 7 sessions. But the research work proving, or the most of the trials, no difference between 6 and 5 sessions or more sessions. 5 is enough.
Okay, thank you. There's a second question. It says, Professor, is there any specific nutritional support in muscle weakness syndrome?
Really, these are good questions. In a patient with muscle disease, they need more protein requirement, more protein content, more vitamins like vitamin B1, B12, folic acids. Need some trace element. Also, high calorie diet. They need more calorie diet because the catabolism here in the muscle disease is very high. So they may need, the adult may need 3,500 kilocalories per day.